Welcome to RealClear Radio Hour, brought to you by the Competitive Enterprise Institute. I'm your host, Bill Frezza. This week, we talk cancer care and climate science with renowned experts from their respective fields. In the second half of our show, we'll head over to MIT to visit with Kerry Emanuel, professor of atmospheric science and co-founder of the Lorentz Center. Up first, we're pleased to welcome Dr. Deborah Patt, Vice President of Policy, Academic Programs, and Strategic Initiatives at Texas Oncology and Editor-in-Chief of the Journal of Clinical Oncology. Deborah, welcome to the show.
Thank you, Bill, for having me.
Deborah, as an expert in breast cancer research, I asked you on because a column you wrote last month caught my eye. You described how a federal drug discount program designed to help the poor actually increased the cost of cancer care. I'd like to walk through this with you step by step. Start at the beginning. What is the 340B drug discount program? When was it enacted, and what was its original intention?
That's a great question, Bill. So the 340B Preferred Vendor Program is a drug discount program initiated for the intent of provision of chemotherapy and cancer services to underserved patients. And so that way, hospitals that use the program were able to purchase drugs at a lower cost and provide care to patients that were or underinsured. Mm-hmm. That intention was great initially, but there's been a lot of expansion of the 340B program.
Well, when did it start?
It started in 1994, Bill, but what has happened is it's been modified over the years and expanded greatly for a number of reasons. The 340B program allows hospitals to purchase drugs at a 30 to 50% reduction in cost. And what's happened in the last decade is there has been tremendous increase in the cost of cancer drugs. So that financial difference between the cost of cancer drugs and the discount has become quite large over time.
Oh, so the dollar margins are going up.
The dollar margins are going up. And even though the program, the 340B program, was designed to serve as a discount for provision of care to under and unserved patients, hospitals that are partners in the 340B program are able to get those discounts on all of the patients that they treat.
Wait a minute. I thought it was designed as an income redistribution plan for the poor. How did it seep into the middle class?
Well, as hospitals saw this, there are certain financial incentives to go into the oncology business for hospitals. The 340B program is one, and the other is they get disparate payment. So they're able to charge more for patients to be seen in the outpatient setting than in the community oncology clinic setting.
Interesting.
And so there are two strong financial incentives to go into the oncology business as an outpatient if you are a hospital. So there's been growth of this program because of the tremendous financial incentives over time. And what's happened is even if there are disproportionate share hospitals, meaning that they provide a great deal of service to patients that are uninsured or have low rates of insurance or public insurance, they then have developed satellite offices that are a little less than 30 miles out from the primary hospital site where the patients that are seen primarily have private insurance. And those discounts also apply to those satellite hospitals. And so it's ended up being a considerable financial incentive for these hospitals to continue to grow their affiliation with the 340B program. And we've seen that trend as you look over the last decade.
So how has the participation rate changed if you track it over time?
It's increased substantially to now about half of hospitals use the 340B Preferred Vendor Program.
And are they all starting to open up these outpatient oncology clinics?
I wouldn't say that they're all opening up outpatient oncology clinics, but what I would say is that we have not had good oversight of the 340B program, and there has not been any oversight to determine how much underserved care these hospitals are providing. And if you look categorically at the sort of the distribution of underserved care, it's pretty equivalent in hospitals that don't have the 340B program and that have the 340B program. So I'll say that if the intent of the program was to ease the burden of serving this underserved population, that is not what the natural consequence has been.
So, Deborah, what happened to the low-cost community oncology clinics as a result of this shift?
A couple of things have happened. Community oncology and private clinics have decreased substantially in the last decade by about 40% of where we were 10 years ago. And the reason for that shift is because it has been financially beneficial for hospitals either to open competitive sites in close proximity where the community oncology clinic has closed, or more likely that the hospital has bought the community oncology clinic. And when that happens, the rates change and the ability to have the 340B discount program initiates. And so it becomes tremendously more profitable for the hospital system. And so the natural consequence may be if Sally is able to get her chemotherapy and be seen in a clinic in January, if the clinic is purchased by the hospital system in February and she goes back in for the same treatment in March, that her bill is going to be on average about 30% higher, and the hospital is able to make substantially more money on the administration of chemotherapy and on visits for seeing that patient.
And this seems to also be driving a lot of consolidation in the industry?
There has been a lot of consolidation as a natural consequence of these financial incentives. It's true in oncology, and in the last decade, you've seen a 40% shift of community oncology clinics close or align with the hospital system, and similar growth in the hospital outpatient administration of chemotherapy-infused drugs. The natural consequence of that shift, because it's a higher cost side of service, is that the cost of healthcare for providing oncology services has gone up considerably. In fact, if you estimate what the change is in the cost of chemotherapy alone over 1 year in 2014, just from that attributable to that site of service shift alone, it's about $2 billion.
So it's often said that hospital finances are all about cost shifting. How addicted have hospitals become to these 340B discounts?
I think that it's a financial opportunity for hospital systems. I think that if you're a hospital CFO, you're oftentimes trying to figure out how to be advantageous for the hospital system, and the outpatient oncology business is very financially profitable. I'll say, Bill, there are corollaries in other subspecialty groups. So if you look to several years ago when you see that in cardiology, their most common procedure, which is an echocardiogram or an ultrasound of the heart, developed a substantial change in the payment system, whether someone was affiliated with a hospital or not affiliated with a hospital. And similarly, the natural consequence of that payment disparity, you saw many outpatient cardiology clinics align with the hospital system. I think many of us doctors often wondered if that was intentional to try to facilitate alignment with hospital systems, because then you could control the hospital systems better from a government perspective. But I don't know their intentions.
Deborah, what kind of moral hazard does distorted chemotherapy pricing create, particularly when it comes to doctors prescribing palliative care that it's not going to cure the patient but might do wonders for their bottom line?
I think that it's different in different scenarios. One would hope that a physician acts as the best agent for their patients. And I think that in medical school, we're all taught, first do no harm, then, do what you can to help your patient. In oncology, first, that is to palliate. And when the opportunity presents itself to cure, we have a lot of cancer progress, so that opportunity is there frequently. But there are different payment systems that do influence how we treat patients. So there is variability between doctors and how they are paid. And in some systems, people are paid to prescribe more expensive drugs. I'll say in the practices I'm familiar with and that I practice in, there is no individual financial incentive to prescribe more expensive drugs, so that kind of financial incentive is removed. But the truth is there's a lot of variability in how we pay for drugs today. And it's a challenge that's particularly difficult for oncology, because for oncology subspecialists, we have to manage that very expensive inventory and manage the administration of those drugs. And so it's a different financial risk than it is conveyed for other medical subspecialties.
So if you look back over 20 years since this 340B discount program came in and you add it all up between Medicare, Medicaid, and other programs, how much is this costing the taxpayer?
Well, a lot. So number one, you see that, as I mentioned in 2014, there's a $2 billion difference just by site of service change alone in the cost of care. That's really more about the disparate payment systems for hospital outpatient services and community oncology clinics. The far greater cost, it's difficult to measure, is if you have a tremendous shift to the hospital system and about 50% of hospital systems have a tax-exempt and 340B designation, then that's about half of hospital systems that are purchasing drugs at a 30 to 50% reduction in cost from the pharmaceutical company. And so if you're the pharmaceutical company and you have this substantial loss in sales to the 340B program, how are you going to buffer that loss of income? You're going to raise drug prices. And so I think the natural consequence of the expansion of this program is that we've seen a wild escalation in pharmaceutical prices, especially in the oncology space.
Deborah, we're 40 years into the so-called war on cancer, yet cancer still accounts for 1 of every 4 deaths in America. Should we be satisfied with this?
We should never be satisfied, Bill. We've made a lot of progress in cancer, actually. If you look at cancer mortality, it's decreased by about 1.5% every year for the last decade. Part of that is because of diagnostic innovation. We are detecting cancer earlier, and when we detect it earlier, we have a greater opportunity to cure. And then therapeutically, we've had tremendous advances in our ability to make cancer a chronic disease. So those changes have been amazing, and you are overwhelmingly more likely to survive your cancer today in comparison to 10 years ago or 20 years ago. So we've seen tremendous success. But Bill, what the problem is in our country is the same problem with many healthcare issues. Our age distribution of the population is changing. If you look at the top of the age distribution, it's narrow and then gets very large right around the baby boomers. As the baby boomers age, we have a much larger percentage of older individuals. It's better than the alternative, right, to stay on the right side of the dirt and live longer. But the consequence of living longer is that you're more likely to have problems like cancer because cancer is a disease related to aging.
Sure.
And so we would estimate, actually, that the cancer prevalence will probably double by 2030.
Well, there's something to look forward to.
It seems counterintuitive because while we're making all these successes in cancer, it's more likely to occur. But even though it's more likely to occur, it's more likely to be cured. And so I think that we are in a fortunate position. I also think it's a fortunate position that we're living much longer lives than we were 10 years ago. And so thankfully, Americans remain in good health.
Even given the progress, how much money do we spend on cancer treatments that don't cure cancer but still provide lovely profits for hospitals and pharmaceutical companies?
It's a tough question because a lot of treatments that we give for cancer don't cure cancer and are still of high value. If I can put a cancer in remission and not cure it ever, but keep it in remission for 30 years, that's probably a high-value treatment. I'll give you an example of that. I have a 38-year-old patient that has metastatic breast cancer. I saw her last year when she presented. She has 3 young boys, and she was carrying around the car seat and sort of thought that her back hurt because she was carrying around the car seat. But as it turned out, she'd had a breast cancer that had gone into her bones, and a large amount of fluid collection in her lungs. It was very serious. But because of this innovation that we have, I was able to put her on 2 pills a day and have her go into menopause and take 2 pills a day, and she's in remission today. And Bill, it's overwhelmingly likely that she will see all of her children graduate high school because of the innovation that we've had in the last 3 years in breast cancer. And I couldn't say that 10 years ago.
And who knows what cures might come along by the time she gets to the end of that road.
That's exactly right. And so it is a real question that we have to ask about value in our country. We do give some treatments that palliate that are very expensive that may not have a lot of benefit, but some of them can keep cancer in remission for many years.
Getting back to the cost side of the equation, you testified before Congress this spring on the Obama administration's new Medicare drug experiment, in particular something called the Part B drug payment model.
That's correct.
Tell us about that.
So the Part B drug payment model was a pilot that was introduced by CMMI. They have been given some authority to introduce pilots, but it would change the nature of drug reimbursement. Right now, the nature of drug reimbursement after the Medicare Modernization Act is based on a paradigm of the average sales price of the drug plus 6%. And that 6% is to do things like manage inventory, which is some financial risk. So they changed the model to average sales price plus a much smaller amount because they didn't include sequestration in there, plus a flat fee. And unfortunately, it's in many cancer centers not enough to cover the drug. And so I'm concerned with that first part of the model that Some places, some cancer centers will not be able to administer appropriate drugs to their patients because they won't be able to purchase them and manage them in inventory because there's too much of a financial risk in doing that. And average sales prices by nature and average, some cancer centers have to pay much higher than that average and then could end up losing money and either not be able to provide those treatments to their patients or have to close their doors or affiliate with a higher cost site of service like the hospital system.
So it's just another form of rationing.
It is a form of rationing, but it's challenging because it's sort of putting it on the doctor. I think that if we are going to ration in our country, which, we do have ways in which we ration today, there needs to be some transparency from the government about how they want to move forward with rationing and have that be a public discussion as opposed to sort of regulating how doctors are able to do this.
Most politicians prefer to be in denial rather than publicly discuss rationing.
It's challenging. I realize it's very challenging, but I think, we have some hard decisions to make. And if we're going to make them, we need to be open and honest about how we will make those choices. Because it's always my job to act in the best interest of my patient. And so if there's a way in which I'm not able to do that, if I'm really not able to do it, I need to be able to be transparent about it. But it's my job to act as my patient's agent. It's my job to always act in their best interest. And so if there's a more global conversation that needs to go on with how we distribute resources, then that's a global conversation. But my job is to act in the best interest of my patient.
Deborah, there's been a movement in the healthcare industry to pay more attention to outcomes data and even think about tying provider reimbursement to actual results rather than efforts. How's that going?
Right now it's challenging, and I'll say it's challenging because there are data insufficiencies in how insurance companies and Medicare are able to look at patient outcomes. So today they get very shallow amounts of data. And so it's difficult to make apples-to-apples comparisons with the patient groups they see. I see a future where that will be very different, where the data that we have on the patients that we treat is very deep. I can tell you, even within my system, within my practice, Texas Oncology, which sees about half of Texans with cancer, the data that we have is very deep on our cancer patients. And so we're able to really give very detailed outcomes in comparison to things like stage and characteristics of a cancer. But today, the payer world and Medicare, they're not able to look at the data that deeply. And so that needs to change, which is a problem of data infrastructure.
Once the data gets done correctly and we can follow outcomes, how do you think doctors and hospitals are going to react if they don't get paid when they provide treatments that don't work or they get docked when a patient dies from, say, a preventable error?
I think that you have to reimburse people for the work that they do, and that, if the financial risk becomes too great to stay in medicine, I think that people will leave or make lower risk choices.
So, Deborah, one of the scariest things that could happen in your life is to get a cancer diagnosis. I actually went through that myself. I'm a cancer survivor. I'm a lucky one. I got a good cancer. It was a thyroid cancer that they were able to cure completely. People who are going through that now, what can they expect in the years ahead? Are we really improving our ability to tackle this thing?
It's a great question, Bill. We absolutely are. So as I mentioned before, cancer mortality has decreased substantially in the last decade, and we've had tremendous innovation. Not only have we learned which cancers respond only to chemotherapy or respond to combination chemotherapy, but we've learned how to better harness the immune system so we can teach our bodies how to fight cancer better. This has demonstrated remarkable progress in cancers like melanoma, in kidney cancers, in lung cancers, in breast cancers, and has really enhanced our therapeutic opportunities. The other thing that we've developed is the ability to provide targeted therapy. When we understand how we can sometimes even in a pill a day alter the sequencing within a tumor, we are able to decrease its growth rate and put cancer into remission. So I have a patient with a metastatic renal cell carcinoma who's been on a pill a day for many years and has been in remission for 8 years from a metastatic cancer, and really just with a pill a day. So this is a cancer that 10 years ago we thought would have an average survival of 3 years. And today, he lives a very normal life. In fact, I live in Austin, Texas, and people are really active here. He actually runs 100 miles at a time. And so is very active and living a very full life, despite the fact that he has what we know is a disease that will likely remain chronic.
What do you make of the real cutting-edge therapies that are still in the laboratory, the genetic engineering technologies, the CRISPR technologies we're reading about? How long before we start seeing some of that in the hospital?
We are seeing some of it. So you might have read about the study in glioblastoma where they engineered a viral vector to treat a rare brain tumor called glioblastoma multiforme. We have studies like that active throughout the country, and we actually have a study like that open in Austin, Texas. We have vaccines to protect against certain types of cancer that are very active. So there's a lot of promise for what the future has to hold, and I think that in my lifetime we will see most cancers be converted to a chronic disease that people will think about in many years like they think about diabetes today. I'll tell you, when I was in medical school, my colleague had her father passed of a chronic leukemia called CML. And shortly after he died, there was a trial published that looked at a pill a day to treat CML, chronic myeloid leukemia. And that one pill a day that hits something called the Philadelphia chromosome changed overnight the average survival of people with chronic myeloid leukemia, that they had lived about 50% to 5 years, and now 95% of them were living past 5 years because of this one pill a day. And so it's interesting, Bill, because I see patients in my office now that take that pill a day and are in remission from their chronic myeloid leukemia. And they tell me about, how challenging it is to take their pill a day. And I think, gosh, if they'd only seen what this was like 10 years ago and knew the tremendous progress that we made, because it would, the likelihood would be that they wouldn't still be surviving had we not made that progress. And so I'm very optimistic for what cancer treatment holds in our future.
Well, Deborah, if you and your colleagues keep it up, you might even cure my pessimism. Thanks so much for sharing your wisdom with us today and coming on the show.
My great pleasure. Thank you, Bill.
That was Dr. Deborah Patt from Texas Oncology here on RealClear Radio Hour, brought to you by the Competitive Enterprise Institute. I'm your host, Bill Frezza. RealClear Radio Hour is a not-for-profit, donor-supported program produced in conjunction with RealClear Politics, America's premier independent political website. To make sure you don't miss any of our shows, stop by realclearradio.org and sign up for updates. Today's program was partially underwritten by the generous support of Donors Trust, the donor-advised fund committed to promoting a free society. For more information, visit donorstrust.org. Ahead, we hop across the river to Cambridge to visit with Professor of Atmospheric Science Kerry Emanuel at MIT. Stay tuned.